This episode is brought to you by podiatrygrowth.com/Pod Patrol.
So for the Pod Patrol listeners, what should they do to take advantage of the assistance that you can provide?
I worked with Jeff here to create a 5-day email course talking about 5 different systems that are going to help you drill down on what's important as far as gaining new patients. And if people enjoy that, I always have the option of 30-minute free strategy session where we kind of go over what people's current challenges are.
So a 5-email introductory course. That sounds expensive. What are we paying for that? $1,000? $10,000? What are people going to expect to pay for that introductory course for them?
Yeah, this is a free gift to my colleagues. Just gives you an opportunity to do a bit of a self-assessment.
If anyone's interested in more information, they can go to podiatrygrowth.com/Pod Patrol.
Every step matters. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters. Feet hit the ground, we rise, we climb. Ain't stopping now, it's our time to shine. Turn it up loud. Pod Patrol. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters.
All right, welcome back to Pod Patrol with your host, Dr. Jeff Dikis. Tonight, I'm joined by Avik Mukherjee. Did I nail it?
You sure did.
Thanks for having me. Thank you so much for hopping on with me tonight.
Thank you. I'm excited. Excited to talk some things over with you, share with my journey. A lot of firsts,
Yeah, give everyone a little bit of a rundown of who you are, where you went to school, and where you're currently practicing.
Yeah, so I'm an Oklahoma guy. I'm from Tulsa, Oklahoma. I went to OU, big college football, sports guy myself. But
Yes.
Oklahoma guy, I went to school in Shoal, did my training in Chicago. I did my fellowship in Jersey. That's what brought me to North Jersey. And then I love Jersey so much, my wife and I decided to stick around, got a good gig. I practice down the Jersey Shore in Ocean Orthopedics. I'm the only podiatrist there, only foot and ankle guy there. So it's been a great gig. I just started practicing about 14 months ago. So I'm excited to share a lot of firsts with you. First job, first time out in practice, just learning stuff on the fly, ebbs and flows of all the firsts. And I'm excited to share some stuff with you.
Yeah, I think that's going to be a great episode for the younger people, especially to hear someone who's fresh out into practice, who just went through residency and fellowship and is kind of figuring out the first year and a half of practice, because that can be rather intimidating. So that'll be our theme tonight, is all the firsts that we go through. So you went from Oklahoma to Chicago, out to Jersey at an orthopedic group. So let's go back a little bit. So you did your residency in the Chicago area. What made you want to consider fellowship?
In my residency, got to see a good amount of trauma. Didn't see a lot of pure recon. So I just wanted to get a better feel of things that I just didn't see a lot of, In different parts of the country, there's different flows in different cities. Some are more podiatry friendly. Some are more foot and ankle MD, in bigger cities and whatnot. And it's just kind of, my training was very much twofold. A lot of my bigger trauma, a lot of the bigger stuff I did was more with my orthopedic attendings. And I was like, I want to learn this, from us too. So I interviewed. I really wanted to be with someone that can have a mentor for life. So then I met Dr. Napoli in New Jersey, and he's such a cool guy. Our interview, we grabbed a beer for happy hour. We talked about life. He was just, I knew the guy, that this is the guy I want to learn from. I want to be a protege of someone, that one person. And he took me under his wing. I owe a lot to him.
Yeah, that's great, because I think a lot of people are on the fence these days. When I was coming through residency, fellowships were, few and far between. There are a few out there, but not as many as there are today. So I think a lot of people are now kind of on the fence. Do I go down the fellowship route? Do I not go down the fellowship route? I'm trying to figure out what makes sense for them. Some of that probably depends on their residency training or how comfortable they feel with certain things, or if they want to get exposed to an entirely different aspect of whatever it may be, trauma reconstruction, limb deformity, total ankles, sports medicine, pediatrics, whatever it may be that they didn't really get a chance to explore in their residency. So once you were done with fellowship, what was your experience with the job market, looking for a job? How did you find a job, and how did you narrow things down?
Yeah, so the just to kind of to piggyback off of why fellowship also, before we get into that, practice management. We learn how to cut, we learn how to round, you learn how to do basic stuff, but understanding how to speak with patients, game planning, one of my mentors told me, well, anyone can cut good enough. It's about when to cut, when not to cut, what to do when cutting goes wrong. Those are the things where, that next level, high level thinking, I just wanted someone to really kind of put me under their wing and show me their ways and learn like that. And that's really what really helped me with fellowship, practicing and billing, coding, all these things, I'm in a private practice, things where no one teaches you. At least it's not in my residency training, I didn't get a lot of, which I like to think that's more normal than not, but understanding that aspect. So then fell in love with Jersey. I really like my reps. I really like my guys that, I used to work with. We had a great system in fellowship. And I love the diversity. I grew up in Oklahoma, and I really like what Jersey had to offer. My wife had a good job here in Jersey, so we decided, well, let's try to find something. First thing I did was this. I'm a very like eager guy. So this was November, December in my fellowship year. That's how soon I realized. So if I started in July or June, I want to be in Jersey. I reached out to my reps. I said, hey, you see me, you see how I work, you see what I do. Maybe put some feelers out there, see what's going on. And some of these reps took me under their wing. Shout out to my guys. And they led me to this group. And what I did was I cold called them. I actually called them. I looked at the website. There was no one foot and ankle. There was no one podiatry. It was this orthopedic practice that had no one there. So I called the front desk and I said, hey, my name is Avik. I like to think I'm pretty good at what I do. Will you give me a shot? And later that day, the managing partner of the practice called me and we had a great conversation. I came down to the practice a week after, a couple of weeks of negotiations after that, I'm signed.
Yeah, I did that too. It's not exactly how I ended up getting the job that I took, but when I was looking for a job, I would call and I would say, "Hey, this is Dr. Dikis. Can I talk to your office manager?" And they don't know any different. They're just like, "Oh, yeah, hold on, let me put you right through."
Yeah.
And I would just talk to. I didn't even know who they were. I was just like, "Hey, I'm looking for a job." Blah blah blah. You like kind of catch them off guard because if you send emails, it's really easy to delete an email. But if you get someone on the phone, they're not just going to click and like hang up on you. They're going to be like, oh, okay, well, I don't know if we're looking into that. Let me look at you're going to get further if you pick up the phone and make a phone call, even though it's more awkward. I remember sitting there being kind of nervous, like, oh, I'm going to make this phone. It was like when you call a girl for the first time, you're like, I don't know. Am I going to call? I'm not going to call. You like start to dial. You're like, no, I'm not ready. I'm not ready. Maybe tomorrow. Tomorrow I'm going to call. Tomorrow, definitely I'm going to call. And then you just get up the courage to call them. And then, what's the worst could happen? They say, no, thank you. We're not looking for someone right now, and move on. But yeah, reps are a fantastic way for younger people who are listening to maybe not find a job, but at least get some
direction
connections.
out,
Yeah, exactly. Figure out, okay, well, they just hired someone. It's probably not them, but like in your situation, hey, they don't have anyone. That would be a good person to reach out to. Fantastic. That was like my job at an orthopedic group. They didn't have any podiatrists. So, all right, let's make this work, figure out if it is going to make sense for us. And it ended up working out for me, at least until we decided to leave. But yeah, I think those are good options. Cold calling is tough and intimidating, but it actually probably ends up landing people better jobs than waiting for some recycled job to hit some job posting board. I do not think that's a great way for people to find jobs for two reasons. Number one, if it was such a good job, why is it still on the board, the job posting board, for as long as it is?
Yeah.
And number two, they're going to get flooded. Let's say it is a good job and it hits some posting board. They're going to get flooded with so many applicants. How are you possibly going to stand out? Even if in theory you are the nicest, best surgeon, best candidate, how would you possibly stand out? It's just difficult to do that. Versus if you cold call and that place doesn't have a podiatrist and you say, I'm the guy, Like, well, all right, maybe you are the guy. Here we go. Let's at least interview him, give him a shot. So I think there's some good tips to take away from that. When you left fellowship, what do you think was the biggest difference between residency and fellowship and how it prepared you for practice? We talked about billing and coding, and I do want to circle back on that, but what else did fellowship necessarily prepare you for beyond residency?
I think residency was get good with a knife, OR skills, rounding, inpatient, trauma, fixation principles. It's like the stuff that, it's the foundation. And I think fellowship it's definitely not the house. The residency is part of it, but it's when to do what, when not to do what, and what happens when something doesn't work out. It's that next level. Yeah, you know how to do it. Good job. But what if they do this? What if this happens and that happens? What if a plate breaks, they fall? Well, are you going to revise the RAF? Are you going to nail it? Are they nailable? Are they old? Are they diabetic? Are these things you're thinking about? Is those things where, I truly believe it's easy to pull the trigger and when to do stuff or to do the things itself, but it's about when to do it, when not to do it, and the price to pay when, sometimes it's just try your best. It doesn't work out. It's not anybody's fault. It's just how the body played out to be. So those are the things that I think really gave me that high level confidence to say, you know what, when I'm out in practice, I can tackle this. I believe in myself and I know when to ask for help. I know I'm fortunate to have a great group of guys that I work with who have been around the block, my partners who will help me out. I commonly show them x-rays. Hey, I'm thinking this. What do you think? Oh, yeah, this and that. It's just knowing that it's okay to ask for help. Like when I do a total ankle and one got infected, called up a plastics buddy. Well, I asked my partners, hey, do you know of any good plastic surgeons around here? And then I ended up becoming good friends with this guy. And then my total joints guy scrubbed in. He's never done a total ankle, but he's one of my older partners, but he knows total joints more than anyone. He knows the principles of that and when to look at what. So understanding that I have this tool belt, the things in fellowship I really learned is, it's okay to ask for help. It's okay to know that you don't know. And it's okay. And the good thing is I built the confidence to be like, I can figure this out.
Yeah. I think there's a huge variety in terms of not only the quality of residencies that are out there, and that's not specific to podiatry, that's true across all medical specialties. There's going to be variety in quality and quantity of cases and all the things that come along with that. But more specifically, there's variability in terms of how much time these residents are spending either in the OR or in clinic. There are some programs that are highly surgical, and I think students get a little enamored with, oh, they do a lot of surgery. And being on the other end of it for as long as I have now, that is not necessarily the greatest thing. Yes, it's great to be around different varieties of surgery, be around different attendings to see how they do different things. But I think that we have a problem with some of the residencies and residents spending too much time in the OR and not enough time in clinic because, like you said and alluded to, billing, coding, complication management, knowing who would make a good surgical candidate and which patients may not make a good surgical candidate and why they may not make a great surgical candidate. All of those things are extremely important that will set you up for either success or failure in the OR. If you only know how to cut, if you only know, okay, I cut here, I open this, I take off cartilage, I throw screw like this, it's kind of caveman in its approach. But then you don't understand, okay, well, I probably shouldn't put a plate on this because XYZ. Maybe they'd be better with a minimally invasive approach, or maybe they'd be better with a fibular nail as opposed to a lateral fibular plate because of XYZ, diabetes, all the things that we know and understand that make certain patients more complicated than others. But my point is, I think to any of the younger people listening that are looking for residencies, don't get over enamored with, oh, we spend so much time in the OR. That's great, but I think that can come back to bite you because a lot of jobs, you end up spending the vast majority of jobs, unless you're some sort of like trauma podiatrist, which I don't even know if that's a thing, you're going to spend way more time in the clinic and talking with patients and doing and billing and coding and doing in-office procedures than you ever do in the OR. Statistically, they're not even close in terms of time spent. What are your thoughts on that?
100%. Like with anything, There's different phases of the ball, different phases of the game. That's just one phase. The whole other phase is like we talked about clinical planning, surgical planning. Then there's executing in the OR. Then there's complications, there's billing and coding. You want to get paid. That's a
And
very
billing
big
and coding correctly too, because sometimes you think you know how to do it, or sometimes you watch just one person do it and they may or may not be doing it correctly. I don't know, but you don't,
100%. 100% that, and just also knowing how to talk to patients, knowing like that's a whole other phase we haven't even talked about, right?
yeah.
Like I think first total ankle-aided. I walk through everything that can go wrong with them. Everything. Not to scare them out of it, saying, hey, shit can happen, and that's just part of it. There's risks, there's true risks and benefits to everything that we do. But how to talk to them. You can scare them, or you can explain, hey, this is what happened. It's a small possibility, but it's a possibility. This happens, this is what we'll do. I'm going to walk you through it. It's just knowing how to talk to patients. That's where I think for me, fellowship in the office really helped. Those kind of things, and just that constantly changes, I think, just in the last 14, 15 months that I've been in practice. That's also changed the way I talk. I talk a lot more now. I really do. Patients love me for it. I give them the time of day for it. But also, they need to know the good, the bad, the indifferent, everything. Things that you don't think about too much in residency, because you do it, you leave. My God, the x-ray looks great. Spot on. But then what? There's so much more to it. That doesn't mean much. I mean, it does, but
Yeah.
you have to have other portions of it too.
Yeah, I think talking to patients is, some people are better at talking to other humans than some people. They just aren't very good at speaking to other people. But you have to understand that the patient is quite different in terms of the knowledge level that you have. And you're trying to dispense your knowledge level to them, but not in a way where you're using all the big terminology. They're just going to glaze over and nod their head. And you think, yeah, they're getting this. And then if you stop them at the end and you ask them, hey, what did he say? They'd be like, I have no idea. But you were nodding your head like, yeah, that's just what they do. I found patients will just nod their head even if they have no clue what you're talking about. So over the years, I've found that there are very good ways. People love analogies. Hey, it's kind of like this. If you think about this, and people love that. And the other thing that I really like to utilize in my clinic is options. Patients really like options. Well, here's your problem. You got a bad whatever. You got an arthritic ankle. Well, let's talk through what the options are. We can start with this injection. We don't need to get into details, but I'm just going to broadly say injection, brace, or we can go down the pathway of talking about different surgical options, and people really appreciate that. So that is a skill that is learned with time because it's a unique situation. It's not the same as just talking to your colleagues because you're going to talk at a different medical jargon level, but talking to a patient with all of the knowledge, trying to give them all the information can be a little tricky. So if you do a program where they do spend more time in clinic, you're going to come out with more polished presentation and ability to speak to patients than a program where you never saw patients because you never saw them pre-op, you never saw them post-op, you just did the surgery and moved on. But yeah, I think you bring up a really good point. Talking to patients is super important. What do you think of your medical decision making? How do you think that changed from residency to fellowship to practice? Because your medical decision making when you're a resident is like, yep, well, they need surgery. We got to fix this. We got to, we're going to cut, we're going to do this. And then when you're a fellow, maybe it's the same, maybe it's not, but you start to think a little more practically and you get out in the real world and it may change a little bit. What are your thoughts?
That's a great question, and I think you just nailed it spot on. In residency, it was about cut. I'm excited. I did this. I'm excited. I'm feeling myself. I feel good. Did a good case. Go home. Forget about it. Next one. In fellowship, you see the same patients. You see them post-op. You see what they go through, and you think about, okay, well, there's more to it, right? That next phase of the game that we're talking about. And then in attendinghood in practice, it's about knowing when not to do surgery. That is the most important skill, because when you're ready, you do 400 or 500 cases in a year in fellowship, and you do hundreds of cases in residency, and you're like, I'm ready. These hands are ready. It's not about that. That's not what it's about. It's about doing the right thing, knowing when not to operate. Pulling the trigger to not operate is showing restraint, showing, in that areas of polish. That's the biggest thing. That's how my decision making changes. If it's a fifth metavulsion fracture, they're 60, boot them, unless it's massively displaced. Boot them, they'll be fine. And if it doesn't, bone stem them. But if they're a college level athlete and they may need something, it's a pseudo Jones or it's more that metaphysis diaphyseal, maybe, they're a good candidate for ORF, for a little perk screw and whatnot. But if they're 80 and they have a Jones fracture, boot them, stem them. They're going to be okay most of the time, is in showing restraint. I think that is the biggest thing. And it's really, I think, bode well for me overall because patients are everywhere. There's no shortness of patients anywhere you go. You'll find people to operate on. It's about knowing when not to, because that's going to be better for you long term. That treating them with respect, kindness, like you said, options will then lead to them telling their neighbors, oh, well, hey, you really took his time with me. When a real surgical candidate comes in, then, they'll trust you. You have that built-in trust.
Yeah.
That would be my answer to that.
And the one thing we didn't really touch on, which is always the elephant in the room, is the medical legal aspect of patient-doctor relationship. And if you can form a relationship where the patient trusts you and they, like you said, you've talked through these potential complications. I think one of the biggest hurdles to get over if you do have a complication is the patient thinking, well, you never told me this could happen. I never knew that this was even possible. So talking about those complications ahead of time, forming that relationship and having them trust you is not only beneficial from, yeah, I got a 5-star review. Yeah, they told their neighbor, that's great, but also from a medical legal standpoint. And that's not why you're doing this, but it is one kind of added benefit component of taking time with people and interacting with them in a way that they leave happy, even in the setting of a possible complication. But medical legal is always floating around there in the world that we live in. And I talk people out of surgery all the time. I used to talk people into surgery. Oh yeah, we could fix that for you. Now I'm like, I don't know. Do you need surgery? How much does it hurt you? Like they almost have to come in begging me for surgery because those are the people, if they're going to have a complication, then they know, oh, well, I wanted, I needed this surgery. I really wanted this surgery. So if anything's borderline, I'm kind of like, I don't know. You gotta, if you're limping to the mailbox, maybe you do need surgery. But I've kind of shifted over time, and now I'm actually talking more people out of surgery. Let them come to me and ask for it. What are your thoughts on that? You're still pretty fresh out, so not that you're trying to talk people into surgery, but what are your thoughts on that?
Definitely talking to people out of surgery more and more. More and more. Like you say, everyone gets that bug in the beginning of, I want to operate. I really quickly got out of that bug because I've had the privilege of being around great surgeons and partners who have instilled that wisdom in me right off the bat. And I learn a lot from them. You never stop learning. You constantly learn. You're always a student of the game. Definitely. It happens. You get that. And over time, you just get less and less. It, it, uh, like you said, it bodes so well. It bodes so well for you talking people out of surgery. You really want them to have it for the right reasons because there'll be enough people. People are everywhere. It's good to think about the long term, think about, like you said, the medical legal stuff. The last thing you want is anything questionable to come back to you. And then that's the one that has issues and whatnot.
Mm-hmm. So we're talking all about first job, first patients, first cases, all that stuff. I remember my very first patient when I joined this orthopedic group. I'm all excited. Oh yeah, we got a bunch of patients ready for you. This is your first day. You show up and you go in, you see the patient. Oh yeah, I know what this is. All right, I can help this person. And then I remember it vividly because it caught me off guard. And I told them we're gonna do this, we're gonna do that, and they were like, all right, when do you want to see me back? And I was like, I don't know. When are you free? Like 2 weeks, 3 weeks, a month? Like, I don't know. Like, I didn't really think about that ahead of time. Let's, I don't know. Are you free next Tuesday? I guess swing by. It was one of those things just so simple. You're like, and of course, now I've been doing it for so long. I know exactly for which thing. Okay, well, it's not going to be better in 4 days. So I'm not going to see him in 4 days. Why don't I see you in 2 weeks or whatever? With each thing, I'm kind of like, okay, well, let's see you in 3 weeks or a month or whatever it may be. But I vividly remember my very first patient. It caught me off guard. Do you remember your first patient or first day or first case or anything that stands out to you?
My first case solo was in fellowship, and middle of it was right around this time in 2023, actually in December. First solo one, no supervision, nothing.
Mm-hmm.
Someone was on call, local to the area. who didn't do a lot of ankle fractures. And I'm just, if there's one thing, you're knowing about me now, put myself out there, cold calling. I told everybody in the area, hey, if you ever need any extra set of hands or anything, I'm a fellow, I'm here, I'm happy to help you.
Mm-hmm.
He called me in and she's like, I don't feel comfortable doing this. Will you do it for me? And I said, okay. And she said, I actually have to go. Will you just do the case? I was like, okay, great. It was an ankle fracture. And I was like, okay, I've done hundreds of these. Let's do this.
Mm-hmm.
And I just remember having this surreal feeling like, hey, first of many, but we did it. You made it. No, don't mess this up. So
Mm-hmm.
then you go at it, and it was uneventful. Everything was fine. Post-op wise, I remember she was 70 something. Trimal, very sweet lady. And she was like, how long have you been doing this? My first post-op. And I said, a dabble here and there. And I tried giving a vague answer. And I just remember, I want to see 1 week post-op. I want to see those stitches looking good. I want to see you 2 weeks post-op. I want to see you 4 weeks post-op. I want to see you 6 weeks post-op. I want to see you 2 months, 3 months, 4 months.
Yeah.
And I followed her like a hawk.
Mm-hmm.
And thankfully everything was uneventful. She did great. She wrote me a thank you card, the sweetest person. But I remembered, it made me realize that's the kind of person I am. I'm careful, and I leaned into it. That's just how I am as a person, and I lean into that. And I think I was very nervous, and I remember that was my first one. And there's a lot of firsts that we'll get into. That was my first stat. Then there's my first complication, which this guy medial mal isolated fracture, in practice now, and just loving guy, fantastic guy, but a knucklehead, just non-compliant. But it is a great guy to talk to. He's a mechanic, medium mal screws, walked all over, backed out, diastasis. And I was like, okay, well, what do I do here? He's in his 60s. He's, do I bone stem him? It's clearly loose. I'm stressing him in my office with a stress film and it's loose.
Mm-hmm.
So I tell him, hey, you gotta be, 4 weeks, you gotta give me at least, like the least you can give me is 4 weeks. He said, I can't do that. He's like, I will not be doing that. I'm just telling you right now. You can rise, but I will not be non-weight bearing.
At least he's honest. He's
At
a
least he's
knucklehead,
honest.
but he's honest.
That's why I really like him. Great guy. And I was like, okay, well, you got a loose medial mal. I got to do something here. So then I brought it back in. I went bicortical, these like 65, 70 screws,
Yeah.
got all the way to the other side of the tibia. I didn't want to plate him because I think he's going to walk all over it. If I do a bigger plate, incision, dehiscence, I'm overthinking this thing. And I said, just please, just don't walk on it. It comes in. I know he's walking. Splint's dirty. I put him in a boot. I'm like, if you're gonna just be more careful in a boot, then at least. Following me did great, but I remember I was, knocking on my partner's offices at that because we have one big office and we all see patients together. I was walking down the hallways to each of my guys saying, what do you think here? What do you think there? I think this is what I'm gonna do. And first, and we'll get into it more as we keep talking. But that was my first case, and that was just my first, complication.
Well, and that circles back on what we talked about before in residency training and understanding how to manage those complications. So, and having those conversations, those are the easy conversations are the ones where you fix them and they're happy and they're like, all right, see you later. Thank you. Bye. Those are easy. They're happy. It's the ones where something goes wrong, gets infected, a screw breaks, a non-union, it doesn't even matter if it's, their hemoglobin A1C is 13 and they smoke 2 packs a day. It's still your mess that's sitting in your office that you have to fix this non-union. So it doesn't even matter that it has nothing to do with anything that you did or didn't do or could have done differently. But yeah, those can be a lot of headaches. And so it feels like sometimes I make it through the end of the day and I'm like, all right, no headaches today. That's a win. And some days it feels like they just like tell their friends like, hey, let's all go in together and let's all just all the headache patients come in on the same day sometimes and just drives you nuts. You're banging your head against the wall.
Well, those are the names you remember. I don't remember
Oh, yeah.
the names of the patients I'm fixing now, but the ones I do vividly are the ones that have a story with it.
Exactly.
Every single one. Those are the ones when I see my schedule for the day, I was like, okay, here we go. What's going to happen? Flip of a coin. Looks good.
100%. So what are your thoughts on surgical boards? So luckily that's in my rear view mirror, but sometimes you can control which patients you operate on from an elective standpoint, but from a trauma standpoint, sometimes you don't get to pick the patients that you operate on. And luckily the people that review the boards most of the time are pretty reasonable in terms of understanding that complications occur, and they're not necessarily going to ding you for a complication. They do want to see that you understand how to manage that complication and manage it appropriately. But what are your thoughts on being someone who's fresh out, boards collection? You're trying to get every case to look perfect because you have to potentially submit that at some point. But what are your thoughts on boards?
I think well, I'm in board collections, just like you said, I'm less than 2 years out. I'm preparing right now. First and foremost, I think I have a weird situation where I was waiting for forfeit numbers.
Hmm.
In my practice, I take a lot of trauma, thankfully, and I love to do it. I passed those really quickly. I was waiting for bunions, really waiting for bunions to walk in my door. So now, thankfully, all that, I have it. And I used to think about it probably the first 2, 3 months out. Okay, well, I got to make this perfect. I'm chasing an x-ray.
Hmm.
And I quickly realized at the rate I started doing cases more and more that enemy of good is great. It just
Hmm.
is. You want to go for good. You want to do what's right for the patient more than anything at any given time. So truthfully now, I don't think about it at all. I just don't, because it's, like you said, I'm fresh out, but I'm forming my machine. I'm putting oil in my machine. I'm trying to become a well-oiled machine. And I realized that the things I can control, there's things I can't. I can't control who's looking at my board's case, what they're going to say or do. What I can control is what I thought was best at the time. And that's truly what I go off of. And I don't think about it at all whatsoever. We'll see how it plays out. But truly, I just try to do what's right every single time. And document, going back to medical legal. If this happened, going back to non-compliance to ankle fractures, we'll go over a case where a diabetic guy went over non-compliant right off the bat. Didn't tell me this time though. Non-compliant, has an organ transplant, nephropathic dialysis, big guy, walks all over. I did a fib nail, medium mallet screws, had to do TTC. And, I told him this and this and this documentation first time with that. So, board collections, to kind of come back to it, it's not in my rearview mirror. It's very much in front of me, but I don't think about it because the cases are there. The numbers will come. Do things right. Document. Do the things the right way. And I don't see why, like you said, they won't understand if something played out the way that we weren't hoping it would.
Yeah, and there's always going to be something that you don't think about that you get dinged for. Mine that I kept getting dinged for was that I didn't put the range of motion degrees of hallux limitus when I did a first CPJ fusion. It's like, I don't even own a goniometer. So if you want me to like lie and put what their range of motion is, like, not good. That's what it is. That's why I did a fusion. Their range of motion is not good. But yeah, I don't even own a goniometer. So they kept dinging like, oh,
Oh,
so then
yeah.
there are things that you don't know, that you don't think about until later. It's like if you read through the scoring rubric, or I don't even know where this information is. It's been so long ago. But there are things that some people probably should read through and know that that's what they're going to be looking for on their, not images, not on their x-rays, but on their clinic notes. And they're looking for, okay, if you did this surgery, did you document this, this, and this? Some of
I need
that.
to be looking at that spreadsheet now.
Yeah, there were a lot. I was like, what? You want me to do what? So, yeah, there were a few that caught me off guard. So, anyone younger, go and look at what they're looking for on a grading rubric, and just make sure you're putting some of that stuff into your notes, because it could come back to hurt you in the future, unfortunately.
Oh
So,
man,
from
thank you for telling me that. I'm a limited to none range of motion MTPJ.
Well, yeah, it's like you move it and it's more of like an x-ray. Hey, it hurts. Look at the x-ray. Okay, we're going to fuse your first UBJ. But, this is one of the examples of like, okay, well, I guess I'm going to get dinged on those points. From a billing and coding standpoint, do you think you learned that mostly in fellowship? You learn that kind of when you get out on your own and struggle through it? Or what do you think are some of the best resources for people to understand billing and coding? Because it is such a prevalent part of what we do every day.
For me, it was all fellowship. 100% fellowship. Knowing, understanding what's a 213, what's a 214, when to use modifiers, what's coupled, what's uncoupled, or what's bundled and unbundled. What can you do? The globals for things, and understanding, this and that, practice management. Well, in a global, you can get an extra, you can't, and other things you can't. It's really, I'm thankful to have a mentor that kind of sat me down from the beginning and really kind of showed me the right proper way. in a very ethical way to how to bill, what not to bill. Knowing, well, if they have comorbidities, you can probably bill something a little higher because they're you're managing chronic conditions. But if you got a fresh young guy with an Achilles and you booked him for surgery because he tore it, yeah, the first one is that's because you booked him for surgery. You can probably go up on it. But if he just has tendonitis, that's your basic level office visit. Understanding all of those things. I learned it in fellowship, and what I did was when I started on practice, I sat down with my billing coding staff and I said, "Hey, you're new to this. I'm fresh out. You haven't done foot and ankle before me." Because I was, first one for a very long time, after a very long time in my practice.
Mhm.
So kind of having those conversations. I still have one I had one just this past Tuesday. I'm very in tune with that, and I try to be understanding, and we're both kind of doing this together, understanding what can I do, what documentation are you looking for this, for that. Um, Constantly learning. I went to the ACFAS billing course, I think,
Mhm.
during my fellowship year. When was it? I think it was in Tampa. I think in Tampa.
Okay.
And yeah, it was a great tool. It really was. Learned a lot from it. I have this big book that has all the CPT codes on it, understanding it. Just to you understand CPT codes, knowing what is what. I have the stuff I do, not bread and butter, memorized. And I'm so fresh out, but I really try to be very in tune with those things because I think those are the things, again, right? Every phase in my career so far, I'm learning newer things I haven't seen before. In fellowship, it was game planning, surgery, complications, whatnot. Now it's billing and coding also, and knowing what reimburses what. Are you in a collections model? Are you in an RVU model? Those things differ and they come in differently. So understanding the whole process. I still have so much to learn with that.
Yeah, the hard part about billing and coding is I think it's just like anything else. Maybe you can equate it to learning surgery, where you have to learn how to hold the knife before you can learn how to make your incision, before you can learn how to spread the tissue and get down to the bone. Point of that is you need to understand the basics of billing and coding, but then the deeper you dig, you realize, well, there's so many weird one-off unique. Well, if you did this and that, then you can well, if you bill it like that, then those are bundled. And then if you do it like this and you do this, then there's some other situation. You're like, how the heck am I ever supposed to understand all the little one-offs and all the little weird things that can happen? So I mean, some of that just comes with time and understanding, and then the weird one-offs become less and less common because you've done that and you then understand how to do it. But at least understanding the basics of how to bill, what we're looking for in terms of coding, ICD-10 codes. A lot of the EHR out there are going to do a lot of the work for you. Even some of the newer EHRs, if you click all the correct buttons, it can do the billing for you based on what information that it has. And I would anticipate in the very near future that AI could assist and almost improve our billing and coding. I foresee it. Well, it'll probably go both ways. I was gonna say that AI will probably make us more money because it'll catch things. Hey, did you know you could do this? But I bet there's people overbilling too. The AI is gonna be like, no, that's not right. You've been doing that for how long? Like, it's gonna bring out the outliers, like the underbillers and the overbillers, is gonna bring
You
it
got to
back
be in
into
the
the
bell curve. You're gonna have to
yeah.
be, and then AI is gonna do the other side for who's reimbursing for us. They're gonna use it in their own targets, and like you said,
Exactly. They're going to analyze your note and say, "Well, you build a da 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 da, but in your note it doesn't say this, so we're going to we're going to dock you down because the AI said that your note didn't satisfy what you build." So, it's a lot going on there, and it's hard because a lot of the patient care you come to find is not necessarily what you thought it was going to be. When you go into this, you're like, well, I'm going to see patients, make them happy. I'm going to give them an injection or a brace or a boot or a cast. I'm going to do surgery. They're going to be happy. And then you get this stack of paperwork and FMLA and disability and workers' comp and billing and coding and modifiers and all this extra junk that you didn't necessarily anticipate or think about when you're like, yeah, I could be a doctor. I could be a surgeon. Yeah, that'll be fun. And all this extra stuff that comes along with it. And billing and coding are kind of lumped into all the extra stuff that nobody's overly excited about learning, but is important on the back end. So those ACFAS coding courses or anywhere you could pick up some extra billing and coding tips, I think it's not going to hurt and it should be helpful. Shout out to my friend Danielle, who teaches those billing and coding courses. We graduated together at DMU, so I think she's a big billing and coding teacher. So shout out to Danielle. When you inevitably have those complications, what's your advice for some of the younger people of handling? Maybe you made a mistake and we've all broken off a K-wire inside the bone, or the drill bit bent, things happen. You drop something on the floor that you weren't supposed to drop on the floor. How do you handle those mistakes when you're fresh out and you're kind of sometimes putting a lot of pressure on yourself to be successful?
Don't shy away from it, and that's easier said than done. And that, when that happened to me, is something my mentor taught me, is just don't shy away from it. It's happened. You gotta uh figure out what the solution is, and think of this where you and the patient are sitting on the same side together, looking at the solution, looking at the problem on a board or on a screen. It's not you versus them versus you at all. If you do surgery on them, you take them under your wing, and they're one of yours now. You have your footprint on them literally for life. So that's the way I try to always talk to them. I look at it. Like, we'll go through it. There's an ankle fracture, first one. Again, all the cases I think we'll talk about is a lot of my firsts of stuff and the stories behind it. And I'm excited to, talk about it with you. There's one we'll go through, medial mouse screw. I guess I was working out a little too hard the day before, and I just pushed that screw in, and I mean, 2-finger tightness. It's bread and butter, and we do it in our sleep. Crack. I was like, oh my goodness. So then I put a K-wire in, cut it flush to bone, got the piece together. Instead of 4 weeks, gave it 6 weeks, coalesced beautifully, and they're doing fine. I told them, hey, your medial mal, this area, it was in more pieces, and it went in there, and the screws didn't hold it, and I had to put a K-wire in. The only difference is you'll be off of it a little longer. It's part of it. And she's like, okay, that's fine. Thanks for fixing me. It was just grateful. It was just being thankful.
Yeah.
It's about how you approach it. It's about the way you talk to them. And that's the one phase of it, right? Is talking with the patients about it, the complication. Then the second phase, don't shy away from it also. If you see something they need to go back and fix, you got to do what you got to do. Sometimes you don't need to fix. Sometimes it's a longer non-weight bearing. Sometimes it's a bone stem. Sometimes it's a boot, a brace, a little more PT. It's understanding, right? What do you really need to do? And if it's best for the patient, you got to recommend it.
Sure. Speaking of those cases, let's jump into a few of those here.
We'll be right back after this. For more information, go to podiatrygrowth.com/podpatrol.
So the people have signed up for the 5-email course and 30-minute free conversation with you to analyze where their marketing needs improvement. What steps can they take next?
Yeah, the next step is a deep dive. It's what I call an online practice x-ray. I look into your Google Analytics, your Google Ads. And then the last part of the online practice x-ray is to provide you high ROI marketing plan. It's a really in-depth diagnostic that will give you a clear direction about what those next steps are to help you grow your practice. This is something I generally charge $2,000 for, but since they're Pod Patrol listeners, we're going to chop that in half and charge $1,000 for this diagnostic. You'll have a written document at the end with the competitor analysis, what you're doing now, and a clear marketing plan to make sure that you can be cost effective when it comes to marketing your practice.
Absolutely. I love to hear that. Paw Patrol listeners are getting 50% off from Jim McDaniel, marketing expert at podiatrygrowth.com. If anyone's interested in more information, they can go to podiatrygrowth.com/podpatrol. All right. So what are we looking at here? This is, for anyone just listening, you're missing out, but tell the people what we've got here.
This was everything that we're going to look at is within my, in my practice. And nice guy, young guy, forklift injury, open fracture.
So comminuted first and second metatarsals mainly.
Dusted first metatarsal, and then, a displaced second metatarsal, distal shaft fracture, really comminuted first metatarsal fracture. What I did originally was X-fix this. Skin was super swollen and there was an open fracture. And I got it in the normal 8 hours, admitted him, the whole normal process, washed him out, closed it, X-fixed. I put a wire in for the second metatarsal down the pipe, and I X-fixed with a mini rail for the first metatarsal first ray.
How much do you care about realigning the first ray? Obviously, for anyone younger, we're putting an X-fix on because the soft tissue is compromised, number one. But number two, we're trying to maintain length. When you get this comminution, there's going to get compression and you're going to start to lose length of your first race. You're trying to maintain length. But are you trying to get that fracture back into better alignment, or are you just trying to span it at that point?
Better alignment. So this, we're actually jumping a few steps. This is after the X fix and everything came off, and this was like 3 weeks after. It's holding. This is after my X fix placements. Originally, it was very shortened, and the open fracture was medial on the first metatarsal and on the second metatarsal. So this is after the X fix, after I took it off, and something happened. What happened was developed a strong hematoma. I closed it over the first and second metatarsals. The whole thing after the next few days turned into an eschar. And I'm like, okay, well, holy cow, I have an X-fix, I have a pin in here. Well, why is this thing turning like this? ESR, CRP negative, white count negative, but it's just getting darker and darker by the day. I had the clinical pictures, I just couldn't find them anywhere. So I was like, okay, well, what's happening here, right? And so then I thought of it, well, if it's infected, now these are the things, right? Your hindsight is always 2020. And then in the next week, I kept him in the hospital during this time to make sure I'm giving him antibiotics, I'm getting ID on board. I was like, okay, well, I don't know what's going on here. So that's okay. I'm going to take the X-fix off. I'm going to take the KO wire out of the second metatarsal, and I just opened this thing up, and it's just coagulated hematoma. It was just young guy, healthy guy, probably a pseudo compartment. He didn't have any passive pain range of motion on his toes, but it was open, right? So actually through the open, he was so swollen. I remember getting my stat in, opening up the compartments through the open fracture to try to pseudo drain it out. But whole thing, it was a hematoma, and it spanned the entire forefoot. So at this time, I took out my hardware because I didn't know if it was infected or not. Got deep cultures, got bone cultures, everything came back negative, and I vacked it. I had this big void across the dorsum of the foot, spanning essentially from the first to the fifth metatarsal heads, that whole area. First time I called in plastics. I was like, hey, I got this. I don't do any split thickness skin grafts myself. I never really did a lot of them, getting them from the calf or thigh. Never really trained in it. I figured, well, I'll give it to the plastics who do it. He said, okay. And then he vacked it a little longer, granulated in, put a split thickness graft over it. This is now about, I think, 3 or 4 weeks after the initial injury. And now I was like, okay, skin looks good. I need to RF this thing. Should I let it be? I'm looking at it, and my decision was, okay, well, let me get him under x-ray in my office. I bent the forefoot, the whole bone was still very unstable. So I was like, okay, well, I got to fix this thing. So now we're at the stage of, this is right before my definitive fixation. There we go. So, I put a little T-plate on. I was able to lag the main portion of the proximal shaft there, and I had a good construct holding this comminuted mess together. It was holding, and I was happy about it. Second metatarsal, I make a second incision. The first thing for all those that are just listening, you can barely see the second metatarsal head. That whole thing went into ABN after all this time, after not being connected. And I was like, okay, well, this is a bummer. So I'm trying to put a plate on the second metatarsal, and it is straight paper, it's wet cardboard, a second metatarsal head. I'm pressing with my freer, and it's just going right down. Like, this thing is not going to hold the plate. What am I going to do? So I grab all the I'm in a hospital setting, and I'm like, get me all the allografts you got. And then, I grab some autographs, some allograft, I piece it together, I bring it as close to I can, I drive this wire down the pipe. And I say, I'm keeping this thing, and I got an instant bone stem on him. And I said, we're going to stem this, we're going to put this thing in, and I hope that this thing coalesces. Thankfully, coalesced beautifully, gave him 4 weeks to be non-weight bearing on it. And he very young, active guy, unfortunate injury, the whole metatarsal head came back to life. And I was very, very relieved at that. And then he went out to do just fine.
Yeah, that's a tough case. Obviously, open is much more complicated, and yeah, that's a lot to deal with.
Intraoperative fluoroscopy pics, and you can imagine, right? That second met head ain't looking pretty. You can barely see it.
Yeah, absolutely. So there's some good learning pearls there from an X-fix management, spanning it, and then obviously the complication with the soft tissue management. Anytime you have an open fracture and these kind of complicated midfoot polytrauma, meaning like either a Lisfranc diastasis or multiple metatarsal with comminution. I mean, they are so prone to have soft tissue issues on the dorsum of that foot, and you got to be very, very careful when you're planning your incision placement in response to these multi kind of, like I said, polytrauma injuries, because you can get a lot of swelling and a lot of issues with skin bridging, and you got to be very careful from that standpoint. So there's a
Yeah, and you can
lateral.
see I said, give me the beefiest K wire you got. I'm putting it down the pipe. I'm going into the Q&A forum. I'm going to try to make this thing rock solid.
Yeah. How long? Do you remember how long you left that in there for?
4 weeks. 4 weeks, and I got an X-ray, and he was just anxious, eager to get out of that, get that pin out at this point.
Sure.
This was his third case, I think fourth with plastics. You know, he's such a patient guy,
Yeah.
the gem of a human being. Very thankful throughout the process. And yeah, funny enough, he was a TikTok influencer. He did videos and he's like, will I be able to go back to TikTok dancing? I was like, yeah. And and afterwards, the last time I saw him, he showed me a TikTok dance. He was back at it, doing his thing, and he's doing great.
What a world we live in. What a world. All right.
Yeah. So nice guy, very nice guy in his 60s. He's a plumber. He's a plumber.
So tell the people, I get a lot of people who just listen, tell the listeners what we're looking at here.
We're looking at a very pleasant guy, no comorbidities. Plumber. He fell off a ladder, and I don't remember the exact mechanism. I think the ladder kind of hit, twisted his ankle. We're looking at a very comminuted pilon fracture, distal tibia fracture, intra-articular in multiple planes, failed in a varus setting. There's a fibula fracture, which is displaced as well. And the whole thing is just failing in varus. A very comminuted and a bunch of pieces. This X-fix was done by one of my guys. I was unavailable for the X-fix at the time, so I X-fixed it and just gave it to me. Soft tissue, very, very swollen. Gave it a full 2 to 3 weeks, let this thing cool down. And I got a CT. CT looks even worse than what this is.
Oh, I'm sure. That thing is broken into 40 pieces. I mean, that's just pieces everywhere.
Pieces on pieces on pieces.
Yeah.
So I was thinking, what on earth am I going to do for this, you know? Well, first thing I told this guy is, you're never going to have a normal ankle. I will bring you as close to as possible, but close is not going to be 100%. We're going for 75% here. That's your goal. And I said, you're looking at a fusion or a replacement eventually.
How old was he?
66.
Sure.
And I told him, I would ideally like to just fuse this right off the bat. And then he said, I don't want a fusion. Just don't give me a fusion. He teaches karate. He's a karate instructor. And he's like, I want to, just give me a chance at an ankle, doc. I was like, okay, I'll do my best. I'll give you a chance, but he ain't looking pretty. And I tell him that. And, I tell him, look, and then in the back of my mind, I'm thinking, well, how am I going to fuse this thing? It's completely dusted. If I pull it out to length, I have to take it out of varus, I have to make it straight. Am I going to do a plate? Am I going to do TTC? What am I going to do with the TTC? It's just going to hold a bunch of mush in the middle. I have to somehow solidify this. So I was like, okay, he really wants it. He understands the full. This is when I read the Riot Act. I'm really conservative. I say everything. He's like, no, I want an ORF. And so I went for it. I planned for a anterolateral incision. I planned for a medial incision, and I did it and then I did a fibula incision laterally. So truly, fillet open this guy's ankle in 3 different incisions and try spacing me out as much as possible. Essentially, anterior incision, cheating a little lateral, medial incision, cheating a little posterior medial, on essentially the posterior face of the tibia medially. And a lateral incision for the fibula. I could have nailed it in hindsight, the fibula. It would have been good for nailing, but I wanted to open it up and reduce it. I went at it. I made my anterolateral incision first to see if I can kind of pull things out. And I started working with that. There's a big posterior mal component as well. I pulled that out. I went medial. I slid the medial plate in to hold everything, kind of sandwich it in true trauma fashion, and then just put the bits and pieces together. The medial mal was dusted. Finding that, it's putting Humpty Dumpty back together, taking my time. This was a 3.5, 4-hour case in total. Redosing that ANSEF in the end of that case. And then in the middle of it, I was like, well, my fibula is fighting me. So then I go for the fibula. That was a quick in and out, fix. Working with what I have in that moment. But clearly you can see I'm using different hardware companies for this between the things. And then everything looks good. I'm putting my drill in for the medial mal. I want to do a home run screw, like a normal oblique screw for the medial mal. The drill breaks as I'm doing the medial mal. So now I have in the distal tibia a solid drill bit. And
He's
I'm over
he's
here
never gonna
not.
notice it with all the other metal in there. He'll never never
And
know the
that
difference.
and I was like, oh my goodness. And I'm over here and I'm just like, what am I doing? At this point, I'm reevaluating everything in my life. And I'm like, what brought me to this very moment that I broke a drill bit in my toughest case to date in practice?
Yeah.
And I was like, okay, you know what? It happens. Keep going. I like to think is a good result. And
Yeah.
did a anterolateral plate for those listening, a large medial plate spanning proximal to essentially mid, just below the mid shaft, high end of the distal third of the tibia, and a fibular plate as well. Told the patient right off the bat, goes back to, a good relationship with patients. He was like, I don't care. Am I going to feel it? I said, no, it is as middle of the bone as it can possibly be.
Yeah.
Absolutely in the middle of the bone. Okay. He was just so thankful to have it. Now, weight bear him for a whole 2 months for this guy. Bone stemmed him I'm a big bone stem believer. If you guys can catch on now, bone stemmed this right off the bat. He started walking in 2 months, in a boot at month 3 back into a shoe. He has pain. He has mild pain, and I told him, look, this is what you get. You live with it until you can't. I take out the hardware, maybe see if that does anything for you, and eventually then fuse or replace. He says, I can live with this. He can ride his motorcycle. He's back to karate. He's very, very thankful. I got CTs afterwards to see how's my articular cartilage looking, how is my joint looking. And it looks good. It's in great alignment, but truly the cartilage was shot, It really was. So,
I tell these people that I can put you back together, but the second that you fell off that ladder, you bought yourself arthritis. There is nothing that can prevent this from becoming arthritic. I don't know if it's going to be next week, next month, next year, but the extent of the comminuted interarticular fractures bought yourself arthritis. And you set that stage from the second I meet them. I say, there is nothing that can be done to prevent this from becoming arthritic. We can limit the chance. We can delay the onset, and I can put you back together as best as I can, but the nature of that fracture is going to cause you problems probably for the rest of your life. But this is a really good outcome. When you start planning this, are you putting things back together with K wires temporarily, or are you using the plate to buttress and hold it and then putting olive wires in there temporarily? Or what are your stages of kind of trying to put this back together?
I did my anterior incision first to get the full scope of the tibia itself, try getting mid tibia, seeing what on earth is going on, and trying to put pieces back together. And then I went medial incision to open up the medial mal to see, okay, well, the whole thing is loose, right? So when I pull it out, where does it want to go? Okay, it's trying to go back into position. So then I start finding pieces there was like 6K wires in here at one point. K wiring everything, beefier pins, the bigger ones, putting it back together, seeing it. Big clamp guy. I mean, we're having big Weber clamps. So we have like 2 or 3 of those at a time. Resident scrubbed in. I hold this, that, everything. Clamps. So there's 3 clamps in here, I mean, for these tibias, he had thankfully good bone stock for his age. So I could trust my clamp to really bite, and hold so I can see, just kind of feeling for it. So one by one, that was my game plan. I went anteriorly first. If you see, kind of putting the very middle fracture, the big piece you see, lining that up with the midpoint of the tibia at the metaphyseal diaphyseal area. And then I went to the medial side, opened it up to that kind of where you see it's failing and bears, and I bring that out to length. And the last thing I did was bring the medial mal out to length, because I'm trying to work proximally and trying to kind of just put it back together. At that point, I put an anterolateral plate on, and that's kind of holding my anterolateral portion out. And I put my medial plate on, and I'm just sandwiched the whole thing in together. And then I was like, okay, my medial mal is trying to go into place. Let me put a home run screw. That's when the drill breaks. And I say,
Yeah.
all right, I think I still put a screw in there. I just put a shorter one in.
Sure.
And in the middle of that, I said, well, you know what? My fibula ain't doing any favors. It's probably holding up my reduction too. So then I just plated the fibula in the middle of it.
It's a tough one. Those are
very tough, very tough. He's about a year out. He's about just a little less than a year out, and ankle swollen, that's how it's going to be for life. Like you
Yeah,
said, managing expectation. That's the name of the game. So just,
absolutely.
yeah,
Definitely. All right.
we can go into that.
Yeah, we can do that.
Yeah, we can do calc fractures. So was a plate guy in residency and fellowship. I don't know how familiar this system is, but I use a mini rail. I use two mini rails, medial and lateral, and I put it on the posterior tuber of the calcaneus, put it through two spanning pins, medial and lateral, in the talar body and the calcaneus tuber, and I can put the two mini rails on. I can pull it in and out of varus, distract the joint. I make a sinus tarsi incision, open it up, lift up the posterior facet. Sometimes it works, sometimes it doesn't. Sometimes I have to do some sort of bone cement or something to kind of like filling in a cavity. Just putting in there to build that up so the posterior facet is aligned. Do a suscentaculum screw for those that are listening from lateral to medial sinus tarsi incision. Two big P to A screws to kind of rebar the whole concept together and wait for that thing to coalesce. Coalesce, coalesce. Calcaneus is a beautiful bleeding bone. I don't use a lot of tourniquet in my surgeries. Calc fractures I will, because if they're young, they'll bleed. And then I get annoyed at the blood, and then I eventually turn off the tourniquet to get a better visualization.
Yeah, I mean, I pretty much do the same thing for something like this, where you have that interarticular posterior facet with a little bit of posterior facet depression where it starts to aim downwards instead of up at the talus for anyone just listening. But yeah, obviously the sustentaculum talis or stable constant fragment, going to aim for that and then put the rebar up and through there, assuming that you can get reduction of that posterior facet. Sometimes that pops back into place okay, and sometimes it fights you. Kind of depends on the extent.
It definitely
of the,
fights me more than it doesn't fight me, and that's when the mini rail concept. I'm diastating that joint at that point, and that has been really helpful for me because then it's easier to, because sometimes when it's really depressed, all I'm trying to do is mobilize that posterior facet piece and just sandwich it with the talus. But okay, it's say an articulation, but the whole thing is still depressed. That's always hard to visualize for me at least, unless I throw these mini rails on, and then I can really understand, I can kind of pull it out of the depression better for me. And then there's a void, sometimes I put my wire in for my suscentaculum screw and I think, okay, is this thing holding? Is it not? I'm looking at a big hole. Well, let's fill this thing with something, something hard, wait the 10, 15 minutes, let it harden up, then drill right through it.
Yeah. These can be either relatively straightforward or they can be an absolute nightmare. Calcaneal fracture is one of those things you get excited about, and then as you progress through your practice and your years, you start to get less excited about them. And
Definitely. And like you said, it's all about managing expectations. A similar concept. I said, your foot's never going to be the same again. The best that we're going to aim for here is a stiff but minimizing pain foot. You're looking at a fusion maybe down the road. It's all like you say. I think with trauma, it kind of sets us up well because they need to have something done. It's all about managing expectations.
yeah, absolutely. And like I said before, is that with the trauma patients, you don't get to pick those patients. Those patients, I was going to say walk, but they crutch or wheel into your clinic without you getting to pick their hemoglobin A1C, smoking status, vitamin D deficiency, plus or minus, maybe a little methamphetamine on the weekends just to, mix it up a little bit. Like all these people that you don't really have a choice of whether they become your patient or not. And so you do the best you can. And I guess you don't have control. You can't control all of those factors. You can control what you can control, which is me putting the bone back together the best that I can.
Yeah.
Telling them to stay off of it for as long as I think they need to stay off of it. But the trauma patients can be quite the adventure. So,
Definitely are. And they come with, unique, like you said, these are the patients you don't choose. They come to you, or you roll up, or you show up to their ED room because you're on call.
Yeah. Absolutely. Well, I want to thank you for joining me tonight. I appreciate you hopping on, giving people a good understanding of many firsts. So the first cases, the first complications, we talked billing and coding, we talked all kinds of things, finding that first job, starting practice, all these things are going to be very helpful for people to hear. So thank you.
Thank you for having me. It's always a journey. Happy to share a little part of it.
Yep. Thank you so much. Dr. Avik Mukherjee. Did I nail it again?
You sure did.
Let's go.
All
All right. Thank you so much. I appreciate you hopping on. And thank you, everyone, for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.
Paw Patrol. Paw Patrol. Paw Patrol.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.